Bismillahirrahmanirrahim. I would like to thank Professor Akhtari Bandeshah for inviting me for this talk. And I have a lot of cases, so I'll quickly go through them.
ਤੁਸੀਂ ਵੀ ਆਰਾਮ ਨਾਲ ਚਲੋ
But I'll finish in time, don't worry, sir. So you all are familiar with this. I need not tell you what to do in antigrade wire escalation, or when these are the few features when we go for a retrograde approach. So our first case is an antigrade wire escalation. Although it is a longish CTO which is ending at a bifurcation, we started with a antigrade first approach with a pilot 200. It went subintimal. So you can see here. Then we changed for a Gaia third. So Gaia third got the true lumen, and we parked it distally. And this is how it looked like. In the end, it's a little bit of dissection distally, but as the flow was good, so this is another case in which our antigrade wire went subintimal. So we got through a tortuous epicardial collateral retrogradely. So it was a Sion black which crossed into the circumflex, and then our wire is in the aorta. But we were unable to externalize the wire in the left-sided guide cath. So we had to do multiple tricks like the Guidezilla. Finally, we had to snare the wire into the left guide catheter. And after that, the RG3 was externalized. And this is after ballooning. And this is what it looked like after stenting. And we had a complication there in the donor vessel. So it's very important to be careful that your donor vessel can get injured, and always take a picture of the donor vessel. So we had to stent this lesion as well, and it ended quite okay. So this is another RCA CTO with an ambiguous proximal cap. So we had a good epicardial collateral with which we started off, but unfortunately our wire dissected the epicardial collateral, as you can see, with the tip injection. So we changed our plan, because if you damage an epicardial collateral, you can end in a disaster. So we went through a septal collateral next time, and our Sion black reaches the right coronary artery. So the Sion blacks crosses true to true. It is in the aorta. And then we had to change the guide cath to sort of re-enter our wire. And then what we did was we passed the wire antigradely, and then completed the procedure through the antigrade approach, and this is how it looked like in the end. So in this particular case, we did a multiple things to. So the antigrade wire is the Fielder XT. So our Corsair is through the septal collateral. So Corsair couldn't cross. We dilated with a 1 millimeter balloon. But as we were ultimately able to, as we were not able to pass the retrograde gear, so we changed back to the antigrade, and we could wire antigradely. What you can see here is that there is a balloon in the guide cath. So what we do is we use it as an anchor balloon as well as a trap balloon. So once we need to anchor, we sort of push the catheter in the branch that is in the conus branch. And when we want to use it as a trap balloon, we pull it back, inflate it, and then remove our gear that we have to remove. So this one balloon on the wire that is on the conus branch can be used as an anchor as well as a trap balloon. So again, we had difficulty in the antigrade crossing. You can see how much tension on the guide cath, but ultimately we crossed with a Corsair, and this is how it looks in the end. So this was a very useful use of the crossboss. We have 100% CTO ISR, And we just use the crossbars from going true to true. You can see distally here the crossbars, which has, without the wire, we have just crossed the crossbars from the proximal edge of the CTO into the distal true lumen. And after that, we just cross with a wire, and sort of this is how it looks. So in another case, so this is again the antegrade dissection re-entry. You can see the wire in the subintimal space, and this is a crossbars following that wire. And you can see here that the crossbars distally part is subintimal. And then we are now using a stingray balloon over a miracle 12 wire to sort of re-enter into the true lumen into the distal RCA. You can see the subintimal stingray balloon with a Conquest Pro trying to re-enter. Now, this is how the stingray balloon should not look like. It should not look like a rail track. It should look like the one in the previous picture, in which you don't see any rail tracks. So our wire finally re-entered in the true lumen, and this is how it looked like in the end.
So you did not use the stingray wire?
No, we usually use the CP12 for this.
It is the same actually.
It is almost the same, yes. So this is multiple approaches for an LAD CTO. So we had this LAD CTO with a very ambiguous proximal cap. We didn't know where to enter, and so we went retrograde. The wire is in the diagonal branch, and we have a microcatheter distally part there. So we have a Xeon black in the distal LAD. Corsair sort of passes it. Now we confirm the injection from the Corsair. We are interluminal in the distally. So now as we didn't know what's going on, so we placed the IVUS where we thought the proximal cap would be, but we were unable to sort of navigate the retrograde wire into the antegrade portion. So we again try the antegrade Confianza Pro 12, but ultimately we were successful in sort of redirecting the Conquest Pro in the. And although it's not an ideal result, but it is quite an acceptable result. Thank you very much.